Let me just acknowledge the recording. First thinking about the third years. In the third years that you're working with, it's really helpful to kind of acknowledge where they are, which is that they've, at this time of the year, they're not too far removed from their pre-clerkship training. They have a great understanding of pathophysiology, but they're really not quite practiced yet in applying that knowledge to the care of patients. They've learned how to do an H&P. They've practiced it. By no means are they proficient. They're really looking for your guidance in collecting a thorough history and reporting it back in a concise and pertinent fashion. And like I said, they're really developing the context for the knowledge that they have and applying it to the real world situations. So more than that, I'd like to just share the objectives that we have for the students in the third year clerkship. Understanding that they're really focusing on applying some of the knowledge that they have gained, you'll notice that a lot of the objectives and expectations focus on that. So they want to demonstrate proficiency in taking histories, performing exams, communicating across all settings of their clerkship. They want to apply the pathophysiology that they've learned to clinical care. They want to kind of take initiative and responsibility in taking ownership over the patient care tasks that you assign yourselves every day. And they really want to demonstrate that they can interact with patients, peers and families and supervisors and other members of the team in a productive way. All of these clerkship objectives are listed in our clerkship information sheet, which I know in prior years we sent out on a monthly basis before each of your rotations. I'll just check in with our site directors to make sure that we're still doing that. But hopefully these are expectations that you can reference each block that you're going to start working with a student to really understand what their expectations are. So those are the objectives. In terms of the kind of day-to-day expectations, most students will feel comfortable carrying about 2 to 3 patients at any one time. And the key expectation, I think, is the one that I emphasize the most for the students is to take ownership of their patients as much as possible. Although they see their patients in parallel with one of our PGY1 interns, they share a patient with the intern. As much as possible, we encourage the students to try to fill the shoes of that intern, to take ownership over certainly being the one to be first in the room to collect to pre-round on the patient, to collect information from the EHR, to certainly, absolutely, they should be the one to present the patient on rounds every day, and absolutely they should write a separate note in the chart every day for the patients they see. But beyond that, as much as they can, they should take ownership over things like calling consults, if it's kind of comfortable for them to do so and appropriate. They should feel ownership over calling primary care providers, over calling outpatient subspecialists to collect history, get collateral from family members or other providers, liaise with pharmacists, both outpatient and inpatient, to perform medication reconciliations, involve themselves in family meetings and teaching the patients and their family about their illness. As much as an intern would be involved in the plan of care for that patient, we'd like a student to kind of try to expand into mimicking some of those experiences. Just a quick overview of the overall clerkship structure. So, and some of this may be familiar to those of you who've been working with our students, but it's a 6-week clerkship with 2 3-week blocks. They all do 3 weeks at Mount Sinai and then 3 weeks at one of our affiliate sites, which can include your site. So you'll have your students for 3 weeks. In addition to the patients that they'll be seeing on the wards, there are preceptor rounds and didactics. So you'll notice that your students sometimes peel away from your team to join a Zoom didactic series, which are usually 2 sessions a week on Tuesdays and Thursdays. And then they'll have preceptor rounds, well, much like many of you had in your clerkship training, I'm sure, where they'll be paired with a separate attending to talk through some of their cases. They do have night float, but not when they're at your affiliate site. So I'll skip over that for now, and I'll skip over the night float rotation. If anyone's interested in hearing about our new night float curriculum, I'd be very interested to share it with you. You may hear from your students about trying to see patients with these conditions. They have an array of required clinical experiences of conditions they have to encounter to ensure that they get an appropriate breadth of training over their clerkship. So just because they may ask you about it, it's helpful to know why they're asking to see patients with these conditions. For their schedule, they'll be with you for 3 weeks. You may not be with them for that entire time, but they'll be there for 3 weeks. And their day-to-day schedule, it looks like this. So they usually come in approximately when you do, and they take call once per week. So once per week, they're there from 7 a.m. to approximately 9 p.m. Or whenever their call ends. On their non-call days, they leave around 5 o'clock. That's the kind of global expectation. They do 1 weekend shift, and as I mentioned, they have the preceptor sessions and didactics. They really enjoy when the residents understand about their flex time, which is 2 afternoons throughout their 6 weeks. They have protected time on a Friday afternoon from 1 p.m. onwards. So please don't be shocked if your student tells you that they have flex time coming up. They're a little reticent to bring it up sometimes, but they are actually not allowed to be in the clerkship during their flex time. They're forbidden from participating in any clinical or clerkship related activity. That's a very broad overview to the clerkship. I'll talk very quickly about the acting internship, but then we'll get into some of the exciting parts of actually implementing your knowledge of their coursework to see how you can be a great teacher. And I'll take a pause for questions in a little bit. So the sub-interns, I always call them sub-interns. I'm getting difficult, having trouble adjusting to the new language, which was acting interns. The acting internship students are obviously at a slightly different place than the third-year medical students. They have finished their clerkship year. And as much as possible, their goal is to really expand fully into the role of an intern, albeit with a smaller footprint of taking care of a smaller number of patients. So the expectations and objectives for them are to really fully expand into that role of being the primary inpatient caregiver. So their objectives here, flow from that to demonstrate independent thinking and decision-making and action in patient care at the level of an intern, I think is the key one on this slide. But certainly they should be collecting history, prioritizing problems by acuity and severity, and interpreting clinical data to form differential diagnosis and management plans as a third year would. But the key difference, I think, is that there's an independence in this process that's beyond that of a third year and closer to that of an intern. Certainly they'll be participating in handoffs and transitions of care, modeling and learning excellent communication, interpersonal communication, demonstrating initiative and reliability, and contributing to the teaching and education on the team. And again, we have a clerkship information sheet, which we disseminate as widely as possible. So these are objectives you have in your pocket and can really use to guide your teaching and work with the students. The day-to-day expectations for acting interns look like this. So they carry usually a panel of 3 to 4 patients supervised by a resident. They carry those patients independently of the intern. And for those patients, they have the full clinical responsibilities at an intern level. They attend all didactics and they behave professionally. Unlike the clerkship students, the sub-internship, there I go again, the acting internship students do all 4 weeks at your site, so they don't rotate. And much like the third years, there are core clinical symptoms that they're trying to see throughout their rotation, although they're not tracked, so you may not get asked as much by the acting interns about their diagnoses. I'm going to take a quick pause for questions about the structure of the 2 clerkships, of the inpatient medicine third-year experience and the acting internship, before I move on to some strategies to really leverage this knowledge to do great teaching. What questions do you have about the structure? Anything that's come up in the past?
So one thing which has come up in the past is the schedule for acting interns. Is it the same as an intern, or would you sort of have a different schedule based on how a schedule would be for a third-year student?
Yeah, by and large, the acting interns would take a schedule that's in line with what an intern would do in terms of their call schedule. The one difference being that they do 1 weekend out of the 4 weeks that they're on. So an intern probably would take additional weekend call beyond that. But for the acting internship, we just ask that they do 1 weekend.
Any other questions?
And Dr. Pergolini, please correct me if that's wrong, but I believe that's what Dr. Barn is doing.
What we are doing is 1 weekend that they're on call. 1 weekend is totally free, and the other 2 weekends they come either on a Saturday or on a Sunday just to do regular work, but without being on call.
Without being on call. Okay, thank you for that clarification. I'm very glad you're here. Thank you.
Sure.
What other questions do you have before we move on? And I'm trying to model one thing we'll talk about later, which is anytime you ask your learners a question, to allow appropriate space and time for them to think of the question, formulate a response, and actually get it out of their mouths. So usually that's 6 seconds. So hopefully that was about 6 seconds for you to think of a question. But certainly we'll come back if there's anything else percolating around that you're really interested to ask. You can put it in the chat. Perhaps I'll ask our chief residents to keep track of the chat, or you can unmute yourself later on in the talk. So great, we'll move on to strategies for being an effective and outstanding teacher. And I think if you learn nothing else from the next 40 minutes, I should actually ask, what time do we go till 2, or it was before 2, I think, right?
I mean, we're okay to go till 2, but we'd like to keep about 4 or 5 minutes.
Okay, I think I saw the invitation was to 1:50. So over the next half hour, really, what I really like you to take home is for all of the learners that you work with, think about setting mutual shared goals and expectations. Always working, as part of your education cycle, to set a comfortable learning environment, which will help with all of the other aspects of being a great teacher that we'll talk about. And to think about giving feedback and being specific based on observations that you've made. So we'll talk about those in much more detail as we move forward. I really like this slide. This is from the Stanford Faculty Development Program about the educational cycle that we move through as learners and as teachers, from setting goals to then going to teach and help our learners learn to meet those goals, evaluate and assess their progress towards reaching those goals, and giving them feedback on that process so they can realign their behaviors to better reach those goals and set new goals. So we'll go through this kind of educational cycle step by step. So first, for goals and expectations, it's really critical that you both you and your learner develop a shared understanding of what they're trying to do, what they're trying to achieve, where they're trying to get to, because that will completely define how and what you teach them, and completely define how you evaluate their ability to do that, how you give them kind of both formative feedback and how they're working towards those goals, and grade them and assess them in their ability to do that. So in person, I usually make this a little bit more interactive, but on Zoom, it's a little bit challenging. I usually ask kind of, what sources you could use to find goals for your learners over the course of the time that you have together. And maybe I'll open it up to a quick question. How could you identify some goals that or objectives that your learners have, your students have over the 3 weeks or 4 weeks they're with you?
This is Matt. You could actually just ask them, what are they hoping to accomplish during this rotation? Like, are there any specific procedures, or, if they have a particular subspecialty that they're interested in, whether they would want more exposure to that kind of patient, et cetera.
Matt or Matthew, I love that answer. And that really gets to one thing I think is key, is making sure you have a shared understanding of what their goals are, and have a chance for the student to share that from themselves. I love the way you phrased it. Another way of phrasing it that I found successful is, what have you gotten feedback on in your prior rotations? Or what have you been working on? What have you been told you should kind of work on moving forward, as another great way of asking it. Because that gets to kind of really their personalized goals. Another place that you can triangulate for goals are the Clerkship Objectives that we mentioned on slide 1, and that we try to send around on our Clerkship information sheets. Those are lists of objectives that I've set and Dr. Barna has set for our students, and are a great place to kind of start with them. You may also want to think about sources of kind of day-to-day expectations and questioning, and how you're going to communicate with each other, how they should reach out to you and when, and what types of questions they should ask you and when. Those are kind of really helpful for students and learners to hear. So just to summarize, you want to kind of think of a multitude of sources to elucidate goals for your learners, and really want to seek a shared understanding and a communication with them about the clerkship's goals for them, your goals for them, and their own goals for the next 3 weeks, or 4 weeks, or 2 weeks, or whatever it is. Okay, so having set your goals, you get to move on to the fun part of being an educator, which is the actual teaching and guiding them in their clinical roles. And we'll talk about some ways that you can do that.
We did have a comment from Ariella in the chat.
Sure.
She says, I would also give them time to think of goals. Example, email them to ask about goals the day before the rotation, or say we would revisit goals on the second day of rotation.
I love that so much for a couple of reasons. One, day one on a rotation always is such a busy time with everybody getting to know a cohort of really complex patients and getting to know each other. So I love the idea of putting it in writing and emailing out the day before. It shows a couple things. One, it just helps get everybody thinking about their goals even before they arrive to the rotation, and will make that conversation more efficient. Two, it just shows that you're a thoughtful and engaged educator, and that's a real signal to your student that you're thinking about your role as a teacher as well as a clinician, and will likely set a really positive learning environment. And then also, if it's in writing, it's just very easy for everyone to go back to later in the rotation. On day one, when there's 1,000 things to learn, it's very difficult to kind of get all of that fire hose inside you, that fire hose of knowledge, and it's very helpful to reference that back. So was it Ariel who said that? I didn't actually see the chat, but I think you said Ariel, so I love that idea. And if there isn't a shared expectations document already that you guys use, for the chiefs, that might be something to consider developing, something that the senior residents can use that's standardized at the beginning of a rotation to send out. I love that. And please keep putting questions in the chat as they come up. So before we start talking about teaching, I think it's just always helpful to point out that we're teaching at all times when we're with learners, even if we don't feel that we're actively engaged in a teaching session. We're always role modeling. Learners are always looking to us. So whether we're at the bedside or on rounds with our attending or in didactics or lectures, or just actually consciously role modeling, we're always in the role of a teacher when our learners are around. Beyond that, we'll talk about some powerful teaching tips that you can consciously hope to embed in your work with our students. We'll go over each of these in a little bit more detail. First of all, this was a quote from William Osler, which Dr. Barna put up here, and I really agree with. An enthusiastic teacher is contagious. Coming to the rotation with enthusiasm and energy will really help your learners kind of mimic that and approach the rotation from a rich educational standpoint. So a kind of corollary to that is a huge part of being a great educator starts with setting a productive learning environment. And sometimes we say comfortable learning environment, but maybe that's the wrong word. We definitely don't want our learners to kind of rest on their laurels. We want them to be challenged. And a little bit of uncomfortableness can be helpful in that regard. So that's the reason we call this a productive learning environment. But some ways that you can promote a productive learning environment are some very simple things, which sometimes we forget, which is to learn the names of your learners on day one. I find that challenging, more challenging than it should be, but when I'm working on a team of 8 people, I used to find that on day 2, there was always 1 or 2 people's names who I couldn't quite bring into the forefront of my mind. So now on day 1, I write everybody's name down, and then it helps me memorize them, and then use the names. Even if it kind of feels unnatural in the first day, just make sure to use their names in a couple sentences in your interactions. It goes a long way towards developing a bond with your learner. A very low bar for setting a productive learning environment is to invite our learners' opinions. Ask them what they think about a case or an interaction, or to offer their opinion and feedback of how they think something went. Just the process of being asked your opinion really helps involve you in the team and feel like you're a part of the environment, and helps you as a learner. I found this one incredibly helpful in acknowledging my own limitations, especially as a resident. As a PGY 2 and 3, I felt an enormous pressure to kind of know everything for my students, to have all the answers all the time. And I think that limited myself as a teacher, and it also affected the learning environment, because you really want to model the process of lifelong learning and getting something out of each encounter, and setting an expectation that it's okay to acknowledge your own limitations. It's okay for them to be curious and ask a question and not be afraid of revealing, sorry, I can't speak anymore, revealing a lack of knowledge or a lack of skill on their part. And that kind of leads into encouraging questions and independent thinking. I think acknowledging your own limitations does that in many ways. And we talked about setting great expectations as well. So, 1, 2, and 3 of being a great teacher, I think, is setting a productive learning environment. And these are some ways that you can do that. Moving on to actually teaching our learners in a clinical environment, there's some other ways we can really leverage that experience. One is many of us have learned by being asked questions in the clinical environment before. A couple things on that. One, we always talk about being asked questions versus pimping. And to me, the only difference between pimping and being asked a lot of questions is whether that learning environment is productive or not. If you have a strong bond with your learner and you're asking them questions, it'll feel productive and a promotion of their learning. Whereas if you don't have a kind of productive learning environment, you haven't set that bond with them, asking a lot of questions will feel like they're being challenged or questioned. So with that in mind, how can you make the most out of the questions you're going to ask of your learners? And there are some different categories of questions that can really be targeted according to the level of your learner. Recall questions are really great for early third-year medical students who just finished their pathophysiology training and study for step 1 and know all of the medicine and amino acid structures that we've certainly forgotten by now. So recall questions, what are the 5 criteria for TTP? That can be a great question targeted towards the third year that they may be better able to answer than even some of us. Analysis, synthesis questions and application questions are, can be great for third years in some senses. They're also great for acting interns, a little bit more mature in their clinical reasoning process. What led you to that diagnosis? Why did you say this was COPD and not heart failure? Get them to kind of name the pertinent clinical findings that support that diagnosis. That'll really help you diagnose them as a learner and understand how they're thinking about a case and identify additional areas for either encouragement of things they really did well and feedback about, a slightly different approach that you would have to analyzing that case and clinical parameters that you really thought made this COPD versus heart failure. Application questions and self-assessment questions are also fantastic. Great for sub-interns or even for your interns. How you treat this pain, how you approach this patient who has a suspicion for pulmonary embolism. And self-assessment. Remember that all of our teaching is directly clinical. We also teach our mindfulness as clinicians and professionals in improving our knowledge and skills all the time. So self-assessment questions, what would we do differently? These are especially helpful for debriefing difficult events. For that patient who had a cardiac arrest, is there anything we could have done differently as a team? Anything we felt uneasy about? Those questions are really helpful for your learner's emotional response to stressful situations, but are also really helpful in advancing their professional characteristics. Okay, so when asking questions, always wait for the answer. I alluded to this before, but educational science has really shown that it takes much longer than we intuit to answer a question. It takes a couple seconds to actually hear the question and understand what the questioner is asking. It takes a couple seconds to formulate a response in your brain, and it takes a couple seconds more to actually kind of get that response into the physical and muscular response of speaking your response. So really, when you ask a question, to give a kind of appropriate time for your learners to go through that process and also develop the courage to actually kind of speak up in a group, which, let's be honest, all of us take a second or two to get that courage as well, it's really important to wait 5 seconds. 5 seconds feels like an eternity when you're an educator in front of one or more learners. It can feel very uncomfortable. So you really have to kind of embrace that discomfort and get used to sitting in silence. I'll time out for you now what 5 seconds actually looks like, if I can get my my timer up here. So I'm going to ask a hypothetical question, which nobody actually needs to answer. But I'm going to say, you know, Dr. Pergolini, what did you have for breakfast today? So that's 5 seconds. And when we're in person, I usually ask someone to kind of reflect on how uncomfortable that was, but I won't make you do that over Zoom. But 5 seconds is an uncomfortable amount of time. But I promise you, it will make you a more effective teacher if you train yourself to do that. Okay, another highly effective teaching technique is to think and reason aloud. I really also like this technique because to me, it lowers the barrier to teaching a little bit. I alluded to being in my role as a teacher, as a second and third year resident, and feeling a lot of pressure to know everything, to have the answer for the case, to be able to access that piece of medical knowledge about the the 5 causes of 5 symptoms of TTP, for example. And if I couldn't kind of immediately reference the answer to the question or the diagnosis of the case, I felt a lot of pressure in being a teacher, and I kind of shut off. What was really helpful to me, and I think is a great teaching technique, is realizing that you're teaching even if you don't have the answer, by just showing your thought process of showing how you're accessing the information, how you're prioritizing the problem, asking the right question, and showing how you're approaching the case. So if it's a patient who you're trying to decide on the cause of the dyspnea and it's COPD or heart failure, you could say, well, I'm not so sure exactly what's going on here. Some things seem to support COPD. He has that diagnosis and has severe disease and comes in with exacerbations a lot, but he doesn't have any wheezing and he does seem to have orthopnea. So there's some kind of conflicting data here. Just modeling that process of how you're approaching the case is hugely helpful for students to kind of have a window into your brain and to see how you think, because you've thought about this 1,000 times more than they have. So thinking and reasoning aloud is hugely valuable to your learners. It's also, at least for me, lowers the barrier a lot to teaching. And I don't think I even recognized that as teaching when I was earlier in my career. It's helpful just to even label thinking aloud to me as teaching. I'm going to take a quick pause because I have to sip of water to ask what questions or thoughts you have so far. Okay, I think that was 5 seconds. Hopefully someone's timing me now. Okay, but we'll move on and we'll certainly have more chance to ask questions in a little bit. Another highly effective teaching technique is extending a case. So, you'll see a wide breadth, certainly in the week or 2 weeks or 3 weeks that you have with a learner. But there's always a way to kind of get more out of each case that you see. And what if questions can be a great way to do that. So for any patient that you see, if you've gone through an H&P with your student and kind of thought about the differential and plan, if you feel like there's some more learning to get out of the case, you could kind of contemplate a what if question. So maybe you're seeing a patient for whom you're considering a diagnosis of pulmonary embolism. And you can ask your learner, what would we do differently if the patient's creatinine was 3 instead of 1? How might we approach the diagnosis in that setting? And similarly, if the patient came in with chest pain, how would our differential have changed if the patient was 60 instead of 20? How would that change our thinking? Or these are also great for kind of anticipatory questions for things like sign out. If we start cefepime for our patient with hospital-acquired pneumonia and they start seizing, what are we going to do? Or tonight the patient spikes a fever, what should our plan be? These are kind of really great ways to get even more out of rich learning out of the case that you've already kind of gone through some of the teaching points for. I'm sure you're not far into the idea of time being tight on the clinical rotations on the wards. Our patients are hugely complex, and we have a large number of them, and there's a lot of turnover, and there's conferences to go to, and interdisciplinary rounds, and documentation to do, and radiology tests to expedite. So time is always tight. Recognize there's a lot of things you can do that are already part of your workday that are considered teaching. One is thinking and reasoning out loud. Another is just modeling, bringing a student with you. First of all, just engaging them in everything that you're doing throughout the day helps us reinforce that productive learning environment. Bringing them to the bedside if you're going to go to see someone who, bringing them to the code, or bringing them to any other interaction you can do. And with the student at your side, you can model things. You can model an exam. Let me just talk out loud as I'm trying to palpate this liver. Even if you haven't found the liver, talk through kind of the process in your mind of how you're going about trying to find it. Model bedside interaction with patients. Think back to when you were a third-year student or an acting intern or a sub-intern, and how challenging that was. Be a great role model in the way that you sit with patients. And model self-directed learning. Understand that showing some weakness is not. I had a better way of phrasing it when I had the slides in front of me before, but acknowledging your own limitations is a key part of being a great teacher. And an analogous thing is self-directed learning. And identifying things that you don't know that you're going to go look up and just say, that's a great question. I don't remember the 5 symptoms of TTP. Let's pull up to date on our phones together to make sure that we don't think that's a part of the differential diagnosis for our patient here. So model self-directed learning and reflection. And again, these are all things that you do every day and maybe haven't felt like teaching in the past to you. We all do really well with setting goals in our lives, and hopefully you're setting goals for your rotations in taking care of your patients. It's also helpful to set goals in your role as a teacher, but make commitments that you think are attainable, that will push you a little bit, but are also attainable. So make small but productive commitments to being a teacher in the next time, for example, you're on general medicine wards. Think about kind of identifying one teaching point each day. Model one bedside interaction each day. Talk out loud through one physical exam maneuver each day. Whatever it is that you and your learner have identified are important kind of learning points. Think about kind of setting clear goals that are measurable and attainable that you can achieve in a given week or 2 weeks or 3 weeks or 4 weeks. So just to sum up this part of the talk, some high-level teaching tips that are highly effective. Work on creating, here I put comfortable learning environment. I changed it to productive before. I think productive learning environment is a little bit better. Vary the level of questions from recall to analysis to application to remember to embrace that discomfort and the 5-second pause when you're asking questions. Remember that you're always teaching through things that you do, like reasoning aloud and thinking out loud, and modeling behavior. And then remember that what if questions can really extend a case. I will again take a quick water pause to ask what questions you have so far, and then we'll move on to talking about student evaluation and assessment and feedback in the next 10 minutes. Okay. All right, so you've set goals, shared understanding of the goals that you and your student have for each other and for them. You've done a lot of high-level effective teaching to help them reach that goal. Now it's time to kind of assess their progress towards their goals and give them feedback. So in the medical education biz, we talk about different types of feedback, formative and summative. Formative feedback is kind of ongoing. It's information that's used to improve your behaviors and your work. It's more like feedback. You're doing that on a daily, weekly basis, even if you don't know that you're doing it non-verbally. But we want to kind of formalize that process. And then there's summative evaluation and feedback, which is kind of what we think of as a final assessment. And from your student's perspective, that would be a grade. So we'll talk about your role in both formative and summative assessment. So for both your clerkship students and your acting internship students, many of you will be asked to submit an evaluation, a clinical evaluation. So a few things to note about clinical evaluations of a person's performance. One is that we're all humans, and there's a huge inter-rater variability among how we observe other humans in their professional interactions. So to try to kind of mitigate that, we have provided an evaluation form which has some fairly clear behavioral anchors. So what I highly encourage you to do is when you get this evaluation form, assessment form, that you read through each of the descriptions under each of the dots and think critically about behaviors that your student exhibited and kind of which description they most match up with. To do that, it's really helpful if you understand going into a rotation the behaviors that you're looking for. So we've asked in the past, and I'll work with your site director, our site directors there to make sure that we kind of get the evaluations out to you, even just in an example PDF at the beginning of the rotation, so that you can see the types of questions you're going to have to answer. Because it helps a lot to have those in your head. And when you see a student taking history or thinking through differential diagnosis, even if they're just in the back of your mind, it helps you kind of really frame how you're going to assess them. So understand the kind of behaviors that you're looking for. And then when you get the evaluation form, please, really line up your student's performance with the behaviors listed. It's very tempting kind of just for someone that you overall think was great to kind of give them the best buttons, and for someone you think was kind of struggling, just to kind of put them all in the middle or the left here. But the behavioral anchors will end up making your experience richer and helping you for the next time you're working with students, and also will be more helpful, both formative and summative feedback to that student. Just a quick word on how our students are graded. Your assessments, the assessments of interns, residents, ward attendings, and preceptors is 55% of the students' grade. So it's a large proportion of the grade that they get. And for our acting interns is even more. 100% of the grade is the clinical evaluations, of which more than half is from interns and residents. So you guys carry a lot of weight, so it's really important that we think critically about giving accurate assessments of our students. Just a quick plug, many of your third year students will ask you at some point to fill out an observed history and physical. This is formative feedback to help them improve their history taking and physical exam skills. So your students may ask you to do that. In our last 5 minutes, we'll talk about the last part of the educational cycle, which is giving students feedback on their behaviors and the way in which they're kind of progressing towards those shared goals that you set, and then resetting new goals based on their progress to date. I'm going to skip the rocket slide because it seems violent to me and we're running out of time. But I think it's helpful to kind of read out this definition of feedback, which is the process by which a teacher provides learners with information about their performance for the specific purpose of improving their performance. There's a huge amount of work and theory in the med ed biz about what goes into effective feedback and why we need feedback. But just to quickly acknowledge that none of us are great self-assessors. Self-assessment is a huge part of being a great professional, but it turns out that we're far from perfect at assessing our own progress. So we really need external input. Very quickly, this is kind of historically some of the elements that have been described as being important for really effective, highly effective feedback. One goes back to the beginning of the educational cycle, which is that the feedback is better if it's based on shared goals and a shared understanding of the direction that the student is supposed to be moving in. If you start from that point, the feedback is much more personal and real and relevant to the student. Number two is that it's well-timed and expected. The student expects you to give feedback. So just setting that as part of your expectations, I will be giving you feedback on every Friday in the 2 weeks that we're together is really helpful in framing the student's expectations. Even just naming the session as feedback is also critically important. Even just saying something as simple as, may I now give you feedback, or I'm going to give you feedback now. It's crazy how our brains are kind of sometimes trained to gloss over feedback, and making sure it's timed, expected, and named can help prime ourselves for success. Next, effective feedback is always based on firsthand specific observations that we've made. So I think the gold standard of giving great feedback is to kind of keep some notes over the course of a day, a week, or a rotation with a student. Keep some notes about some things that they've done really well, or some things that you think they could improve upon. Because if you give them specific examples of, yesterday when you took that history from Mr. X, you really did a good job of collecting a broad array of history, but you didn't stop to acknowledge the difficulty he was having with his wife's recent passing. And next time I would really, make sure to take a time out to acknowledge the difficulty he was facing. That's a very specific encounter-based observation based on one encounter that will have a lot of relevance to the student. They'll understand what you're talking about. So effective feedback is based on firsthand data, observations that you've made directly that are specific and really limited to remedial behaviors. It's tempting, although very difficult, to give feedback on someone's kind of personality. I would highly, caution you towards getting into that kind of feedback, because that's not something that is really fixable, at least with your level of training or my level of training. Focus on things that are specific and things that can be fixed. Okay, so just a few, specific tips that follow on from what we know about effective feedback, which is to make sure that it's scheduled and predictable. Make sure it's not just at the end of a rotation, that the student has a chance to respond to the feedback, both that it's actionable enough to respond to and that there's enough time to respond to the feedback based on your interaction. And that happens if you have a mid-rotation compared to an end of rotation feedback. Make sure to name the feedback, label the feedback as feedback, and focus on specific behaviors. Lastly, if you're super engaged and enthusiastic and may have a ton of observations, attempting to give feedback on everything you've observed, limit it, in each encounter to 2 or 3 things that the student can focus on. Otherwise, it becomes impossible to see the forest through the trees. And then create a shared plan moving forward. If we think about our educational cycle, if you finish your feedback session by helping the students strategize towards setting new goals and strategies to attain them, that will kind of close the educational cycle and help you and the student kind of have worked great together and you have been a great teacher and them to have been a great learner. So I'm trailing off there because I'm running out of time. I do see that there was something that popped up in the chat as a question. It was a podcast a link, which sounds great. Did anyone else have any thoughts or questions, or ever put did Raphael want to kind of reference the Curbsiders podcast that went up?
Yeah, I shared that because it's a really good episode regarding just how to provide feedback. I think it goes a little bit into, or I don't know if you could tell us a little bit about exactly how would you deliver that feedback. There's a lot of talks where a lot of people mention, the feedback sandwich, which might not be as good. Exactly, like how would you recommend just giving these pearls of wisdom or whatever?
Yeah, that's a great question. I would be happy to come back for a full session on feedback because it requires its own hour or its own day. A lot of us were trained in the feedback sandwich, which would give a piece of positive feedback and then give the meat, which is the kind of constructive feedback, and then finish with something positive. The trouble with the feedback sandwich is that it always ends up being quite bready, that we focus on the positive just because we're all naturally good people and we want to focus on the good. And also there's been a lot of research on as a learner, where also our brains are kind of triggered to focus on the good things that we've done. So a lot of times the feedback sandwich, you emphasize the bread and not the meat. So one method that I think I've found particularly helpful is ask, tell, ask, which is starting from the position of asking the student what parts of their clinical work do they think really went well, where they surprise themselves, where are things they want to keep doing, and also one thing that they're working towards it's still a struggle for them, to get their kind of own self-assessment. That will kind of help ground the feedback for as long as this is when it kind of gets into a longer discussion. But especially if you share their self-assessment, it'll help kind of ground the rest of the discussion in a shared understanding of where they are. And then you kind of share your observations that either support or kind of augment their own self-assessment. And then you finish by, that's the tell part, and then you finish with ask, which is to kind of ask them to kind of strategize with you in creating some new goals and strategies to reach those, to respond to that feedback. That's a very brief description. So I don't, you know, I'm happy to answer any other questions about that in the next few minutes we have. Anything else you would, having listened to that podcast, Raphael, that you would layer on top of that?
Yeah, no, I think that's a perfect like summary. They used another mnemonic called adapt, but it's basically the same thing. And it is, like you said, a pretty in-depth discussion. So I would encourage everyone to listen to it, because it also goes into, you know, not just how to give the effective feedback, but how to give bad feedback and how to get, like, you know, the learner to be receptive towards it, because it can definitely be, you know, considered a little bit embarrassing, insulting. So really goes away, really describes effective strategies for that. And also it goes a little bit into like giving, you know, gendered feedback and how, like, you know, our own implicit biases. So that's, I found that pretty useful as well.
I love that. That sounds like a great thing to read on your next run or bicycle ride or commute. So I fully support that. I think I'll go check it out as well. I don't know, do we have time for one or two more questions, or are we kind of up against our stop time?
We have time for questions in case anybody wants to put something in the chat or unmute themselves. I don't see anything in the chat right now, but in case anybody wants to unmute.
I will also say, I mean, please keep think of any questions you have. I'll also say that I know you have some outstanding resources in your program leadership through the residency program. If anyone has additional questions or thoughts or needs some guidance, I would be happy to also be a resource. I can just give you my email address, or you can send it around, but you can also find me in the system. It's horatio.holzer@mountsinai.org. And always happy to hear someone who's thinking about their role as a teacher and would like some guidance. Or if you're interested in medical education, always happy to find someone to mentor in that sphere as well.
So if you don't have any questions, thank you for joining us, Dr. Holzer.